Trigeminal neuralgia is a condition characterized by sudden attacks of facial pain along the distribution of the trigeminal nerve and may involve one or more of its branches. The trigeminal nerve runs from the brainstem out to the face and has three branches: the ophthalmic, maxillary, and mandibular branches. As the nerve emerges from the brainstem, the area just outside the brainstem is called the root entry-exit zone. It is called this because at this exact same anatomical location, sensory fibers are entering the central nervous system while motor fibers are exiting the central nervous system. The root entry-exit zone can become compressed by a neighboring artery, most commonly the superior cerebellar artery. When this artery compresses the nerve at this location, it causes demyelination of the nerve root. The loss of myelin leads to three major consequences. First, ectopic action potentials or spontaneous nerve firing. Ectopic action potentials are repeated spontaneous nerve impulses that occur without any external stimulus. This happens because loss of myelin exposes the axonal membrane, leading to abnormal redistribution of ion channels. As a result, there is an increased density of sodium channels at the damaged segments, which lowers the threshold for nerve firing. In addition, mechanical irritation from the pulsatile compression of the superior cerebellar artery further triggers abnormal depolarization. As a result, the nerve fires without being stimulated. So, again, the first consequence of demyelination is repeated spontaneous nerve firing, which is manifested as a sudden, shock-like facial pain. Second, ephaptic transmission. Ephaptic transmission is when an electrical impulse in one nerve fiber directly jumps to the axon of a neighboring nerve fiber, leading to its activation. There are no synapses and no neurotransmitters, just leakage of the electrical impulse from one fiber into another. Because touch fibers and pain fibers lie close together, this results in allodynia, where normally non-painful stimuli such as light touch, talking, or chewing activate pain fibers. Third is central sensitization. The repeated abnormal firing leads to hyperexcitability of neurons in the trigeminal nucleus and reduced inhibitory control. Over time, this causes pain to become more easily triggered and more severe. If you're not familiar with demyelination or loss of myelin, you can watch the Pathophysiology section in multiple sclerosis video, which will be attached or available in the link below. Peak incidence occurs in the elderly and is more common in females. There are three main types of trigeminal neuralgia. The first and most common type is classical trigeminal neuralgia. It occurs due to compression by the superior cerebellar artery at the nerve entry or root exit zone, as mentioned in the pathophysiology. The second type is secondary trigeminal neuralgia. It occurs due to an underlying pathology, such as multiple sclerosis, tumors, arteriovenous malformations, and head trauma. Finally, the last type is idiopathic trigeminal neuralgia, which means there is no identifiable cause. Patients experience a sudden unilateral facial pain that is extremely severe and described as shooting or stabbing pain, similar to an electric shock and followed by a burning ache. Each episode usually lasts a few seconds but can occur up to 100 times per day. The pain is triggered by facial movements such as chewing, talking, or touch, including brushing teeth or washing the face, and worsens with stimulation. Because pain is triggered by touch or stimulation, patients may avoid eating, leading to weight loss and an increased risk of depression. Trigeminal neuralgia is a clinical diagnosis Although MRI is not required for the diagnosis, it should be performed at least once in the patient's lifetime to rule out secondary causes. According to the International Classification of Headache Disorders, the diagnostic criteria for trigeminal neuralgia include recurrent unilateral facial pain within the distribution of the trigeminal nerve. The pain is characterized as severe, lasts from a fraction of a second up to 2 minutes. It is commonly described as electric shock-like, shooting, stabbing, or sharp in quality. The pain is triggered by normally non-painful stimuli to the affected area, such as touch, chewing, or talking. Finally, the pain cannot be better explained by any other diagnosis listed in the ICHD classification. Treatment options for trigeminal neuralgia include both medical and surgical approaches. During acute attacks, the patient may receive IV lidocaine. For long-term management, carbamazepine is the first-line treatment. Lamotrigine, phenytoin, and gabapentin are second-line options, but they're generally less effective. Analgesics are not effective in the treatment of trigeminal neuralgia. For surgical management, microvascular decompression is an open surgical procedure. It can be performed to move the blood vessel compressing the nerve root away from the trigeminal nerve. Ablative procedures are additional surgical options that may be considered in selected patients.
If you have any feedback or ideas to help us improve the channel, let us know in the comments. And don't forget to like, subscribe, and turn on notifications. Thanks for watching.